Welcome, everyone. So my name's Hazmer Cassim. I'm a physician here at Eisenhower Medical Center. I work with Desert Orthopedic. We provide comprehensive treatment for pain and part of our spine center. So thank you for being here today for my lecture, which is going to be pain management, past, present, and the future. So pain has always been something part of our civilization, part of our society for centuries. No one really knew what pain meant. They just knew it was unpleasant. Nobody knew how to fix it. Nobody knew how to treat it. All the way from the days of the Egyptians, the Greeks, the great civilizations of our time and our history tried to figure out a way to solve the problem of pain. The first breakthrough really came with this colorful flower you see in front of you. And this flower is known as an opiate poppy. So this flower soon became very famous with all the ancient civilizations because it had a very numbing effect. Now, for those of you who don't know, opium comes from this flower. If you cut the bud of the flower, a milkish white liquid comes out, and that, if used properly, can be very numbing. And that's a picture of the clear liquid coming out of the opiate poppy. Soon the potency and the power of this liquid became very popular all across Europe, Asia, even in the United States. A lot of opium dens begin to pop up where people would go in there, smoke opium, forget their worries, and opium became a very critical medicine in treating pain. For centuries, opium and many of its different versions were used to help with pain. So that brings us to today, where we're going to spend some time looking at how the past has shaped the way we treat pain today and what we see in the future. So most of you out there suffer with pain. Some of you have neck pain, some of you have low back pain, mid back pain, perhaps, headaches. Sometimes this pain goes down your arms, your legs. Your activities are limited because of this pain. Simple things like walking, doing the dishes, standing could be limited because of pain. Sports, tennis, golf, all different activities are limited because of pain. How do we help people living in pain? Beginning with the opium poppy that I spoke about, opium became the main way of helping those with chronic pain. And pretty soon, opium, alcohol, and even cocaine was used as treatment for pain. And if you look at this picture here, it says cocaine tooth drops for children. And if you look at the date, that's 1885, not very long ago. So the past practices of treating pain that originated from the days of the Egyptians 5,000 years ago eventually came down to hundreds of years from us. And still things such as cocaine, opium, and alcohol were the main means of controlling pain. But as time went on, people started realizing there needs to be a better way because obviously cocaine and opium had some negative side effects, which even in the early 1900s, people began to realize that there's got to be a better way. So this gentleman, American neurologist Corning, injected 111 milligrams of cocaine into the epidural space, performing the first epidural injection, and started a concept of localizing treatment. Rather than general treatments where people would take medicines, he started focusing on localized treatments to help people suffering from different types of pain conditions. And technology began to improve. Röntgen, in 1845 to 1923, he was a German physicist. He won a Nobel Prize in physics, came up with X-rays or discovered X-rays. And pretty soon, these X-rays, or X-rays because they're mystery rays. They didn't know what they were, but he knew they existed because that's the first X-ray ever taken, and that's a picture of his wife. You see the ring in her hands. And in the early 1920s, someone could go in to buy a pair of shoes, and you put your feet in little boxes, and you could take X-rays of your feet. Obviously, people didn't know the dangers of these X-rays. So there are definitely a lot of negative side effects. And all these technological improvements, medical improvements that happened in the past allowed us to shape the present treatments that we have. 1914 to 1918, 1939 to 1945 were the First and Second World Wars. Massive casualties, death, and lots of pain. During these periods of human history, there was an increased need to help those suffering on the battlefield. And a small little company called Merck at that time identified the most active substance in the opium poppy we spoke about. And in 1827, there was commercial production of morphine. And during the First and Second World War, morphine came into the world stage. Every soldier had a little vial of morphine that they took with them to the battlefield. The medic definitely had morphine ampules. And if anybody had an injury, they would receive morphine. And if their wounds were very severe, they would receive enough morphine so that they would not feel any more pain at all. With the success of morphine, mainly in the First and Second World War, civilian populations and civilian physicians looked at this as the solution. This is a funny little meme, so to speak, where here's a guy saying cocaine, heroin, opium, and morphine. We call that medicine. The field of anesthesia started to grow using the X-rays that were discovered, as well as regional anesthesia with the epidural injections. They started using injectable morphine, and slowly you see modern medicine take shape here. So if you look at all the different technological breakthroughs in the past, they had many problems, especially with the X-rays and not realizing the dangers of X-rays, with cocaine and opium, and using these to help many different groups of people with pain. All these different treatments used in the past has shaped the present treatment of pain. So we come into the modern era of pain management, and there's an explosion in opiates. Makes sense though, because the First and Second World War saw such success with morphine that many companies jumped on the bandwagon to produce oxycodone, OxyContin, methadone, Demerol, Tylenol 3, Tylenol 4, different means of giving these medicines, fentanyl, transdermal, and transmucosal. So you had an explosion of all these different brands of opiates, and physicians believed that these medicines were the solution. And if somebody had pain, just like they did in the wars, you take it. And if it didn't solve the problem, take some more. So there was no limit to how many of these pills somebody could take. And in the 1970s and 1980s, this was the main way to control pain. They even created stronger opiates. Diamorphine was a very, very strong opiate that was synthetically manufactured. But soon people realized that there were problems. Diamorphine is now used as heroin. So as you can see, these opiates have a very strong addictive tendency. And people began realizing there was also a lot of deaths with these opiates. This is November 2010, coming more into the modern era, where people are beginning to think that maybe opiates were not the solution. So what's the problem with opiates? Well, your body gets used to it and you need it. If you stop the opiates, suddenly you'll go into withdrawals, which have many different symptoms: abdominal pain, runny nose, and it's not a comfortable process. So the dependence is caused by opiate use. Tolerance, this is another property of the opiates, where after a while, the dose you're on doesn't work anymore, and so we had to go to a higher dose, leading to increased side effects and danger. People also began to realize that there was abuse, where people were really overusing these medicines because it felt good. Addiction is a little different than abuse, because addiction is when people are so hooked on these drugs that they're willing to break rules, sacrifice things to get these medicines. And then a newer concern, and this was actually documented in a National Geographic show, where they saw people going from physician to physician and buying these and getting these medicines and selling them on the street. Diversion is an illicit sale of medicine. So as you can see, opiates were becoming more of a problem than a solution to pain. Recently, we discovered something called hyperalgesia. It's called opiate-induced hyperalgesia, where the higher dose of opiate you take, the more problems you have. So opiates at higher doses, instead of helping you, actually caused more pain. So this led us to question, truly, what is the solution for pain? How do we help people in pain? And opiate may have a role in pain. Definitely if somebody breaks a leg or has a gallbladder taken out or has spine surgery or brain surgery, opiates help in the short run. Or what we call the acute pain period. So this is when we began to really specialize and focus on the localized treatments for pain. That machine you see there is a C-arm. It's an X-ray machine. There's a patient under that blue covering. And on that X-ray you see in the screen, it's a picture of the spine. C-arm X-rays revolutionized the ability to put medicines in different parts of the spine. We can rotate that arm you see on that machine and take many different angles of the spine or any part of the body, really, and get medicines exactly where we want it. For instance, if people have low back pain and the pain runs into their legs, they've tried pain medications, they've done exercises and nothing works, we can do a epidural steroid injection. The picture you see in front of you is a very precise injection to the fifth nerve coming out of the left side of somebody's spine. That black line you see coming a little further away is the needle, and that black nerve coming out of the spine is actually a contrast dye we put in there. So people come in, we lay them on the table, wash their back, numb their back, slowly guide the needles to the nerve, and we can help reduce pain from pinched nerves, help reduce sciatica with this procedure. And by doing this very specific, simple procedure that takes about 5 minutes or so, you eliminate the need for opiates, eliminate suffering, pain, and improve individuals' ability to function. And this is another very specific injection. It's called a facet joint injection. Again, what you see is a little black line on that facet joint. And below that, you see a little black line that covers the facet joint, where my dye shows me that I have the correct place. So after we put a little dye in there and we're certain we're in the right place, we put the anti-inflammatory medicine, which is a corticosteroid. And again, here you see a very beautiful, this is a picture where we see a beautiful outline of the sacroiliac joint. And that's another very common reason for low back pain, specifically with people who've had low back surgery. All the pressure of movement falls on this joint. And by reducing inflammation in this joint, we can help reduce pain, eliminate the need for opiates, and help people get back to strengthening their muscles. Again, what you see here is a side view of the vertebral body The spinal cord is, I wonder if you can see, I don't have a pointer, but the spinal cord is on the left side, and that black line coming into the vertebral body is the needle. You see the dye on the anterior part of the vertebral bodies, and that's along a chain of nerves, which we call the sympathetic chain. This is called a lumbar sympathetic block. This block is very useful for people who have migraines, people who have something called complex regional pain syndrome, people who have phantom limb pain, and a variety of different pain conditions that are sympathetically mediated or mediated through this chain of nerves in the front of the spine. So as you can see, there are a lot of different things this localized and very precise fluoroscopic guided injections can treat. And so people felt very positive about this with the explosion of interventional therapy. Medications were being controlled a little bit, and people felt like they had a good handle on pain management. However, even to this day, if we look at the statistics, to this day, over 100 million people in the US suffer with chronic pain, $550 billion a year for treatment and consequences of chronic pain. And it's very tough for those living and suffering with chronic pain. So despite the many different treatments we have, the medications, the injections, surgeries, physical therapy, chiropractic, acupuncture, all these different types of modalities of treatment present today, chronic pain still is a problem. So the treatments of the past, the techniques of the past, and the lessons we've learned of the past brought us to the present, where we felt like we had a pretty good handle on pain. We started using more localized treatment with the X-ray machines. We started using less pain medicines. We've realized that there's an opiate pandemic. We need to go down on the opiates. We are using different types of treatments, but still pain continues to be a problem. And that's where we look at the future and talk about how can we get a better handle on chronic pain. And here's the concept that will take us into the future, and that's to use a comprehensive treatment plan. A comprehensive treatment plan is not just using one thing at a time to treat individuals with pain, but many different types of treatment to help the whole person. Medications are important. They help people get through the day-to-day activities. They help people function, reduce pain. Muscle activity, muscle stretching, muscle strengthening, the physical therapy piece of it is the most important. It's the foundation of treatment. Targeted therapy like injections, and that's done with many different types of treatment, different types of guidance, and we'll talk a little bit more about that in the future. I mean, fluoroscopy or X-ray was the main means of getting medicine to specific areas, but targeted therapy, behavior modification, that's another very important thing. So for instance, if somebody has low back pain and they come to me in my clinic and say, "Doc, I have low back pain when I golf," and I ask them and they say, "I golf 6 times a week," well, that's a problem. Or they say, "I have neck pain and I spend 8 hours a day staring at my computer," that's a problem. So behavior modification is important. And also there's a increasing understanding of alternative medicines. Some alternative treatments are very controversial, but there's a lot of evidence behind certain alternative treatments like acupuncture. The ancient Chinese believed there were these meridians that ran down your body that control pain. But we know today that by putting little needles in your body, you release endorphins, and that's how acupuncture works. There's also a lot of increasing evidence for hypnotherapy. So today, most treatments are done one at a time. A patient may go to physical therapy for a while and then, see if it helps, then get an injection. But really, the best way to help somebody with pain is get them in to do all these different treatments at the same time. Get some physical therapy. If physical therapy is limited, get an injection. And while the injection is working, your pain is reduced so that you can do more effective therapy. Get some alternative treatments, modify your behaviors, strengthen your muscles. And as you can see, we're using each different type of treatment to strengthen the other and make improvements to pain. And a new model that's emerged in terms of managing pain is a pain center. Here, you don't have just one physician, a physical therapist doing his thing, and a proceduralist or the interventionist doing his treatment, and a surgeon working away separately. In a pain center, you sit down and you have a collaborative treatment plan with different specialties working together to optimize outcomes. And when you do this, you really effectively use the comprehensive treatment plan. And multimodal therapy, as they call it, or many different types of treatments. So what's new? Well, let's talk a little bit about pain. What is it that causes this unpleasant sensation? So let's imagine we're going to cause some pain on someone's fingertip by sticking them with a needle. As soon as you feel a needle stick your finger, what happens is there are little free nerve endings. All right, they're called nociceptors. Nociceptors are specific receptors only for pain. They respond to, heat, pressure, anything unpleasant. Now, this could come from an acute event, like say you touch a hot pot, or something chronic, like arthritis, degenerative disc disease. Okay. Now, we're having a little computer stall. Oh, there we go. So what happens if you touch a hot pot? Well, the pain travels all along these receptors and through the nerve fibers all the way through your body into the spinal cord. It enters at the posterior or back part of the spinal cord into what we call the dorsal horn. Okay. And the dorsal horn then sends this signal across to a very specific road. And this road travels all along the spinal cord. It's called the spinothalamic tract. That's a pain track or a pain road that takes the signals to the brain. Now, that's very important for us to know because we've learned a lot about pain in terms of what we call the microscopic workings of our cells and how they cause pain and what causes this unpleasant sensation. And we've realized that, again, we need many different types of treatments to change this. So now we stop using just opiates, which are medications for pain, but we use other medicines too, like something called neuropathic medicines like gabapentin, Lyrica, or SSRIs, medicines that work with the brain to reduce mood changes. All these different types of medicines affect pain on a cellular level, affect that spinothalamic tract, affect the dorsal horn, affects the peripheral nerves. And if you use topical medicines, that limits the nociceptor's ability to perceive pain. So as you can see, we have so much knowledge today, so much information on why this comprehensive treatment model with a collaboration in a spine center is really the best way to help people with pain. Also, the means or the technology to get medicine to specific areas is getting better. If you see this is a physician. He's got a C-arm or fluoroscope that we spoke about, but he's also using an ultrasound machine. Fluoroscope is great to look at the skeletal structure. But what if I want to put the medicine in a specific muscle or muscle layer or a bursa? The ultrasound is very good at showing this for us. Ultrasound shows us soft tissue, while the fluoroscope is not it cannot do that. So this is an ultrasound guided shoulder injection. And another way we can use to do specific treatments is called an EMG machine or electromyography. what we do is we connect this device to people's arms or whatever region we're treating, and we put a little needle in connected to the machine, and then we hear sounds of muscles that are spastic or having contractions or increased activity, or muscles that are causing pain. And we can go inject different kinds of medicines there. We may not inject steroids. We may inject medicines that weaken the muscle or loosen the muscle, like Botox or phenol. So we definitely have a lot of different techniques in terms of getting different types of medicines to specific areas. We had the fluoroscope initially. Now we have ultrasound, we have EMG, and a lot of different guidance or extra eyes for us physicians and providers to get the medicine to the right place. We also know a lot about the pathology and the cellular structure of pain. And so we are using lots of different types of medicines at the same time, not just the opiates, but different types of medicines to help with the pain. But the technology itself is getting sophisticated. Treatment options are getting sophisticated. So this is a type of treatment called neuromodulation or spinal cord stimulation. On the left, you see a guy using a little technique to get the needle into the epidural space. On the right side, you see an X-ray picture of that. And these are two little wires people can put in the epidural space. And that's the space where, that's the space in the spine where we can put some anti-inflammatory medicines. And these two wires, those little black dots you see, send out different electrical signals. And it confuses the spine's ability to send pain through that road I showed you, the spinothalamic tract. So the message will come in, as I showed you on that picture, to the dorsal horn. But if these wires are in there, it confuses the message and it doesn't let it cross over into that road that goes to the brain and pretty much stops pain going to the brain. So very sophisticated technology that is getting better with time. There are many different types of spinal cord stimulators available now. There's something called DRG, dorsal root ganglion stimulators, where instead of putting the leads traditionally, we actually put them around the nerve. So the picture on the right with the railroad looking black dots is traditional spinal cord stimulator, and on the left is the new one. It's called DRG, or dorsal root ganglion stimulation. The newer technologies allow us to capture specific areas like just a knee or just a foot. So if somebody has had knee surgery and knee replacement and still has knee pain, we could capture just the knee. We could capture just an elbow. Or if somebody has neuropathy and they have tingling in their feet, we can capture just their feet. And there are lots of different types of stimulation we can use as well now. We can use something called burst stimulation, where people may feel a vibration sense in the affected area, or they may not feel any sense, but just have pain relief. So as you can see, there are a lot of improvements, not only in our ability to visualize and deliver the medicine to the right place, but in the medicine itself. And in this case, the medicine is the electrical impulses released by the spinal cord stimulator. Another treatment that's been used for a long time but getting very sophisticated is the intrathecal pain pump. This is a device that looks like that on your screen. It looks like a hockey puck. It's implanted, and it helps people with chronic pain. We fill the hockey puck up every 3 months or so with a variety of different types of medicines. And that medicine is delivered through a little tube or catheter into the spinal fluid. And what's the advantage of that? Well, it is more effective in the spinal fluid than taking the medicines orally. For instance, 1 milligram of morphine going in the spinal fluid is equal to about 300 milligrams of oral morphine. So very strong response in the spinal fluid. So obviously we don't use that much. We use something called microdosing, very low doses of medicines. And since if you take a pill by mouth, it goes through your liver and it can affect your body and has a lot of negative side effects and causes constipation, by sending the medicine into the spinal fluid, you really have very limited side effects and the medicine's much more effective or powerful. Again, as you see, we've developed different ways of giving or delivering medicines to people for pain. You now have patches you can put on your skin, like Butrans patches that go through your skin, medicines under your tongue for cancer pain, and different means of delivering medicine. So as you can see, the technology is improving, but also the type of medicines are improving. And now what you see on the screen is a type of treatment called a ablation or rhizotomy. And this is a type of treatment that we use for people with arthritis. For the longest time, people with arthritis were given just opiates. And in the present and even in the past, people would just get higher and higher doses of opiates. There was really not much people believed that could be done for arthritis. Now, this is a treatment of somebody with left-sided low back arthritis, where the little joints in the back have lost their cushioning and the joints are rubbing against each other. The three lines you see on the screen are three needles that have been placed next to nerves. And then you see a little a wire connected to that needle, and it goes to a machine that allows us to test the nerves and then put heat and dissolve the nerves away. When we dissolve these nerves away, it takes a little while for them to dissolve, 3 to 6 weeks. You get rid of the arthritic joint's ability to send pain signals to the brain. Now, this doesn't mean you become a Superman and you won't feel any pain anywhere, but just the chronic pain is eliminated. This type of a procedure, the ablation or rhizotomy, is done not only in the spine, but also people with knee problems. And in Europe, it's done for shoulder and a variety of different parts of the body. And this is something that's getting to be more and more popular in a way to kind of get rid of the pain, reduce the doses of pain medicines. And once the pain is reduced, we really push that physical therapy, home exercise regimen as part of a comprehensive pain program and pain center. And again, this is a picture of that ablation or rhizotomy. You see those little red needles on the nerves, which we call medial branch nerves. And that red area is where these nerves are burnt. And that gives you a lot of benefit in arthritic pain. And again, this picture that just popped up is showing you the technological improvements. You know, radiofrequency rhizotomy, even 10 years ago, took a long time to do multiple joints. You'd use one needle at a time, go from joint to joint, and you'd have to burn it with very high heat because of the limitations of technology. The newer machines allows you to burn 4 nerves at the same time. And if you look at that needle on the right in the picture that popped up, it's got a little V look to it. We call it the venom needle, mainly to be dramatic and, you know, show off a little bit. But the real purpose of that venom needle is that it burns a bigger area and gives people a lot more benefit. All right, so as we go into the future, you know, you realize, obviously, opiates are not the solution. Realize that even though opiates might have a role in pain management, mainly acute pain, we need to use other medicines, such as the anti-seizure medicines, centrally acting medicines. And we know this now by truly understanding the cellular level of pain, where the pain signals go through the dorsal horn to the spinothalamic tract. So our increase in knowledge about pain has allowed us to realize that. We've also improved technology, which allows us to deliver specific medicines much more accurately. We rely on the X-ray or the CR machine, but we've also got ultrasound, we've also got EMG to help guide us. And the medicines themselves have improved. We used to have only corticosteroids or cortisone to inject in different areas, which is still effective. But now we have neurostimulators where the electrical current is delivered to specific areas. We have pain meds delivered into the spinal fluid, and we have much more precise technological treatments. Also, another type of treatment that's getting very popular and very successful is something called PRP. This is platelet-rich plasma. The idea here is that if someone cuts their hand, that cut eventually heals. The cutting of your hand signals actually the platelets, which is a substance in your blood. These platelets signal all the healing molecules to rush to that area, and it starts healing that area. That's why if you have an injury, it heals. So the theory or the treatment behind using this platelet-rich plasma is we collect your blood. Okay, we come to a clinic, we collect your blood, we spin your blood. And by spinning it, the different cells go to different layers, because the red blood cells are heavier than the platelets, and the platelets are right in the middle there. And we take these platelets out and we inject it into problem areas. We can inject hips, knees, facet joints, epidural spaces, many different areas. And this works a little differently than cortisone. Cortisone reduces the inflammation. Here we try to create an inflammation where all the cells rush to that area, but we're not getting cells that are going to cause problems. We're getting cells that want to heal the area. And that's how the platelet-rich plasma works. Also, you all have probably heard a lot about stem cells. What are stem cells? So this is a very controversial aspect of treatment. Now, stem cells are the baby cells that can become any different cell in your body. Okay, you can have stem cells in the bone marrow or even in adipose or fat tissue that, if properly harvested or properly counted and properly taken, theoretically they'll become new cells that heal this area, heal cartilage, heal bone. We're not there yet where we can really regrow parts of your body. And you have to be a little careful, because there are a lot of people out there just kind of taking fat cells, and this is a problem across the world actually, where people just take some fat cells, do a few things to it, and inject it in your body and say you're healed. And some people claim they can heal cancers and regrow your cartilage. That's not true. We're not there yet. But stem cell therapy really could be the future if used right. Imagine we're able to harvest the cells that have the ability to regrow structures. We don't have that yet, but let's say we can truly harvest those cells. And let's say you have a degenerated knee joint. What if we could deliver the cells in that area and activate those cells to do what they did originally and regrow the cartilage? And there's a lot of research, a lot of studies going into this. We're not here yet, but stem cell therapy could become the future of pain management, where we can, instead of reducing the inflammation or burning nerves around a joint, actually help a joint heal, help a joint grow. Maybe someday we'll have that. And there's a lot of studies, like I said, they're mapping the genetic structure of individuals. And another thing that people are working on is trying to figure out why certain people feel pain more than others. Obviously, this is a complex subject. It comes from, not just the structural problems, because think about pain. All right. Think about pain and all those people we spoke about a long time ago in the opium dens, right? Pain is not only a physical problem. Everyone agrees pain is unpleasant. That's true. But it's not only a physical unpleasantness, it's also an emotional experience. So pain is defined as an unpleasant physical and emotional experience, which means if somebody's depressed without any physical problems, they have real pain. You think about those people, some people commit suicide, they kill themselves because they're in so much pain because of depression. Some people with gunshot wounds to their leg are able to tough it out, with some medicines, and they heal and they recover. So pain is such a complicated phenomenon that we need to truly understand the physical as well as emotional aspect of it. And as we go into the future, we're learning a lot more about people's genes and genetic expression, why people feel pain more. So it's a combination of culture, education, genetics, mental state, and type of injury. We originally thought it was just type of injury, but so much more to pain. So we've learned from the past that there are a lot of different side effects from treatments. We've done opium, heroin, and alcohol, and even though they give us some benefit in the short run, they definitely have a lot of side effects. Live in the present, where we are using all the tools we have right now, but we definitely want to believe in a future where anything is possible. Thank you very much.